So back to my story. So people thought, well, this is an ideal mode to use for babies because it's pressure support, and the nice thing is, if there is either apnea or periodic breathing that occurs with the neonates, after a predetermined time that I can set on my apnea delay of 10 seconds or 5 seconds or 15 or whatever the case may be, the ventilator will go to these backup settings, provide some puffs of air through the prongs 30 times a minute or 20 times a minute or whatever you thought would be appropriate rate, and at an I time of whatever you thought would be appropriate. And then when the ventilator recognizes a trigger again, the ventilator would cycle back and begin to deliver the pressure support breaths again. So everybody thought that was going to be the cure. The problem with this is that this is real pressure support ventilation, just like it would be for an adult or a pediatric patient intubated. And that means that the patient has to trigger the ventilator into one of these breaths. Okay? So let's say we set the pressure support at 6, but what happens with babies when you're using prongs or a little mask, we're always dealing with some level of leakage. Plus we're dealing with a little, 1,000-gram baby too. They don't necessarily have the strength to trigger the ventilator in a traditional way like we would be able to if we had a closed or almost closed system with an endotracheal tube. So what happens is they started using this and they put the prongs in and they go, well, wait a minute, he's not triggering the ventilator. And he's not triggering the ventilator because the prongs that they were using were smaller than the nares, and when he breathed in through the nares, he was pulling air in through the space and not necessarily through the prongs, but if he did pull in through the prongs, it wasn't enough to trigger the ventilator even at the most sensitive setting. So what was happening is the ventilator would say, oh, he's breathing, or the ventilator would say, I don't detect any breaths, so after 10 seconds it would always go to backup. So, the therapist would say, Jim, this isn't working, the ventilator's always going to backup, and I said, well, remember I told you that this was really only intended down to 3 kilograms, and actually, speaking as a respiratory therapist, I would say that we probably should say more like 5 kilograms, because you would need a good sized kid that had a good strength that could overcome the leak and still transmit a pneumatic signal back to the ventilator in order to trigger the ventilator into pressure support breaths. So this mode was out in terms of using it for, ventilating a 1 kilogram kid. So then some creative therapist said, well, wait a minute, what if we did this? What if we used pressure control? Because let's say the intent is that we're not so concerned about ventilation as we are having some type of stimulus, so that when we have this periodic apnea and these the periodic breathing and the apneas occur, that there's some stimulus there that will stimulate them to start breathing again. So they said, well, what if we used pressure control? Now I know on its face it's like, why would you want to use pressure control non-invasively through a set of prongs? And because you're thinking, okay, every time he triggers, he's going to get whatever pressure control level he gets, and we're going to overventilate them, right? Because it's like assist control ventilation. But keeping in mind that kids can't trigger the ventilator, particularly when we're using an interface that is a little bit too small for the nares and the mouth is open and fussing. So what they found is they said, okay, let's use pressure control. Let's set a rate at some nominal background or backup rate, we'll call it. In this case, I'll just set 20, whatever peak you want, whatever FiO2, whatever I time you want that breath to be delivered for. So let's say we're going to set it for 0.4. And then a rise, which is how aggressive the ventilator is going to be delivering that breath. Then what happens is that when we're using it this way, the ventilator, because it can't be triggered by the kid, is going to deliver 20 puffs per minute through the prongs. But in between those 20 breaths per minute, there's a leakage flow being applied, because that's how non-invasive works. It applies, if it can't maintain, or depending on the size of the leak, it'll deliver more and more flow to maintain the pressure and PEEP settings that you have. So in between those 20 breaths, the kid is simply breathing CPAP. It's breathing the continuous flow that's running through the circuit and then 20 times a minute the kid gets pinged with a pressure control breath of whatever you set, 8 or 10 or 5 or whatever. And then if he stops breathing in between those breaths, the next mandatory breath that hits him is in essence similar to flicking the kid's foot with your finger, and he starts breathing again. So it's a stimulant. So people found this to be somewhat successful. Now, it didn't work all the time, but for a lot of nurseries it was really helpful to use it, and I go into nurseries all the time and they're using it this way with prongs in non-invasive ventilation. So does that make sense to you, that rationale? And I would say, if somebody would say, well, isn't that off-label, or is this off-label use? And I go, well, I don't think it's really off-label. I mean, you're using a mode. You're not using the mode in a different way. I mean, you're still setting a rate. You're setting an eye time. You're setting it. It's just that the ventilator isn't triggering all the time because the baby can't trigger the ventilator all the time. But you're not using it, quote, off-label. You're not generating or delivering it a different way or whatever. You're still using the mode in the same way that it was designed. It's just that he's not triggering it all the time. So that historically is what happened. So then after that, people said, well, that May thought, well, we're not going to use it that way, but we would like a mode that we can use on our 500-gram babies. So we ended up coming out with nasal CPAP. I am just a mess here. I've lost the pointer finger. Oh, thank you. So we ended up with coming out with nasal CPAP after these two modes came out. Nasal CPAP is just nasal CPAP. It's very simple. It's more like, you can think of old-fashioned continuous flow CPAP, where you set a CPAP level, you set a pressure, there's no backup, there's no nothing, there's just CPAP. And so you set those two values. It's pretty simple. Put the prongs in, and there's a flow going through, and you breathe, and it's pure, and it's good. It's good CPAP. It's pure CPAP as compared to using a device with a manometer and setting up a little PEEP column and all that. You know that you have an accurate CPAP level delivered. It's just that there's no bubble associated with it, so it can't be bubble CPAP. It's just plain CPAP, if you will. So this was what was specifically designed to use with prongs, not caring about leakage, and the babies don't have to trigger to get a flow. They will just breathe the flow that's running through the circuit, just like any other CPAP device. But the problem is, this would be great if it had a backup, right? This would be perfect. So and the way this works, so serious or tired.
Don't do that.
Sorry about that. Here, how about if I do it this way? So we have a CPAP level, and every time I move the lung, we see a little movement and pressure going down and then up again because it's the movement. And you can see that I'm, just flicking the lung, but I'm flicking it, creating enough movement so the ventilator can measure this flow change of what's occurring as a result of the test lung moving in and out. And that's what the ventilator uses to count the rate. The only problem with CPAP, the way I see it, is that sometimes if you don't have a good seal, now the rate's low. Oh, and the nice thing about non-invasive, of course, is you can turn the audibles off on the alarms. So you'll still get a visual, but you can turn the audibles off non-invasively. So what happens is...
Let's don't do that.
sometimes the leak is enough, so the baby is still breathing, still getting the benefit of pressure, but because there isn't enough deflection of the upper flow to the bottom flow, it can't count the rate. So sometimes we'll see, even though the baby's breathing, the ventilator will give us an apnea alarm. Okay, because it's apnea now, and it can't count that rate. So if it's fluctuating, if it's variable, you know, it happens, and then he takes some deep breaths, not because but because he went down a little bit and then started breathing. You can set your apnea time out longer so that maybe he won't violate it quite so often, and you won't have the nuisance alarms